A warm good afternoon to one and all. Brace your seats for another episode of Clinical Club of Transfusion Medicine Academic Society. We have today with us Dr. Jyotis P., an alma mater of Government Medical College, Ernakulam, and she has done her MD Transfusion Medicine at Jubilee Mission Medical College and Research Institute. Ma'am is currently working as Assistant Professor and Blood Bank Medical Officer at Government Medical College, Kotte. She also serves as resource person to KESAC's state-level training program for Blood Bank Medical Officer and staff. A lifetime member of IMA, ISTM, and ISBTI, she has various publications in national and international journals. Immunohematology and clinical transfusion is her fields of interest. Welcome you, ma'am, to share this program.
Thank you so much for that introduction. I would like to thank Dimas for this opportunity to share the session. Today we have two really interesting and clinically relevant topics. First topic is evaluation of an acute transfusion reaction, a case report, which is presenting by Dr. Shivanand H. Kumadagi, is junior resident from Sri Chitra Tirunal Institute of Medical Sciences and Technology, Trivandrum. And Dr. Shivanand, over to you. You can start the presentation now.
Okay. Good afternoon, everyone. Myself, Dr. Shivanand Kumadagi from Department of Transfusion Medicine, Sri Chitra Tirunal Institute for Medical Sciences and Technology, Trivandrum. First of all, I would like to thank the TMAS Clinical Club for giving me this opportunity. Today, I'll be presenting a case report titled Evaluation of an Acute Transfusion Reaction, which is a case report. I'll be explaining under these headings, which includes the introduction to transfusion reactions, which includes definitions and classifications. Then the details of the actual case report. Then we will try to evaluate based on these details and arrive at a diagnosis. Then we will have a discussion about the transfusion reaction, which is relevant to this case report. And then I will conclude with a summary. Coming to introduction, any undesirable and unintended occurrence which occurs before, during, or after transfusion is known as an adverse event. These adverse events can be near-miss events, incidents, and adverse reactions. When there is a deviation from the standard operating procedure that is discovered before the start of transfusion, that could have led to a wrongful transfusion, that is termed as near-miss event. In this case, the transfusion has not taken place and the adverse event has been prevented. When the patient is transfused with a blood component which did not meet all the requirements for a suitable transfusion. For example, we might have issued an expired unit, or we might have issued a RBC unit with less hematocrit, or it was intended for another patient. It may be FFP unit which was intended for the same blood group but for the other patients. In those cases, it may or may not result in a adverse reaction, but that adverse event is termed as incident. And if there is undesirable response observed in a patient and that is temporarily associated with the administration of blood or blood component, then we term it as an adverse reaction or a transfusion reaction. Today we'll be dealing with this transfusion reaction. In this picture, we can see that adverse events can be either near-miss events or incidents and adverse reactions, where some of the incidents can lead to adverse reactions. If we want to classify these transfusion reactions, broadly, we can say there are infectious and non-infectious transfusion reactions. Infectious ones are the less common and I can say less reported ones, which includes transfusion transmitted either bacterial, viral, or parasitic infections. In the non-infectious category, either it can be hemolytic or non-hemolytic. Hemolytic consists of some acute reactions, which are known as acute hemolytic transfusion reactions, or it can be delayed transfusion reactions, or it can be delayed serological transfusion reaction. And if in case of non-hemolytic, some of them can be delayed or acute. Acute consists of those which occurs within 24 hours. The common ones are the allergic and FNHTR, which occurs within 4 hours, or it can be severe ones like transfusion-associated acute lung injury or transfusion-associated circulatory overload, which occurs within 6 or 12 hours usually. And there are some other acute transfusion reactions which are non-hemolytic, which are known as transfusion-associated dyspnea or TAD, which occurs within 24 hours, or it can be transfusion-associated hypotension, which occurs usually within 1 hour of the onset of transfusion. We can also classify these transfusion reactions based on the system involved or the main pathophysiology. If it involves hemolysis, this comes under hemolytic transfusion reactions, which I already mentioned in the previous slide. And if it involves the systemic reactions, it can be FNHTR allergic or post-transfusion purpura, TAGVHD, or transmitted infections. But there are some transfusion reactions which involves the cardiorespiratory system. It mainly consists of either TRALI-TACO and transfusion-associated dyspnea TAD or hypotensive transfusion reaction TAH. So today's our area of interest will be cardiorespiratory transfusion reaction. Coming to the details of the case report, this was a subject of 68-year-old female. She had past history of type 2 diabetes mellitus, systemic hypertension, bronchial asthma, and severe aortic stenosis. She presented to cardiology department and she was diagnosed as a case of coronary artery disease with severe aortic stenosis. So the department of CVTS planned to go ahead with the procedure of aortic valve replacement, and they sent the blood requisition requesting 2 units of PRC for the perioperative use. And on evaluating the blood requisition form, we came to know that historically she's O negative, and there was no past history of transfusion, and the history of pregnancy revealed that she conceived 2 times and she delivered 2 viable infants, and they were living now. And weight of the patient was 45 kg. The pre-transfusion parameters revealed that the hematocrit platelet count, PTNR, was within normal limits, and she had moderate anemia. And before the day of surgery, we did the antibody screening, and it was negative. And we cross-matched and reserved 2 units of ABO and RH specific and AHG cross-match compatible. Then on the day of surgery, initially we issued 2 cross-match compatible units which we reserved the previous day, and they utilized those 2 units for priming the cardiopulmonary bypass machine, and the event was uneventful. In the later as the OT progressed towards the end, they decided to transfuse 1 unit of RPC and 2 unit of platelets. And first unit of RBC was transfused. It was requested intra-op, and we issued a AHG compatible unit only, and it was uneventful. And they transfused another 1 unit of LRPC also. This was also uneventful. But they noticed some undesirable response in the patient when they transfused 1 more unit of LRPC, whose unit number was 201615, and it was within expiry date. And when they transfused that unit, they observed some undesirable response. And just to note, the patient was under anesthesia during this episode, and the patient was managed in the operation theater by the attending anesthetists, and the blood center was notified immediately. And they reported to blood center with the form after stabilizing the patient, and they sent a fully filled transfusion reaction reporting form with 1 EDTA anticoagulated and clotted sample and the remnants of the blood bag. Initially, we checked for the patient identifiers, and they were matching on the transfusion reaction reporting form, blood samples, pre and post transfusion, blood bag, and initially we ruled out the clerical error. And on examination of the post transfusion sample, there was no hemolysis and no contamination, and the volume was adequate for the further immunohematological workup. And when we examined the blood bag, 40 ml was remaining. 40 ml was remaining, and there was no visual RBC contamination of this platelet bag. Then there was no discoloration, and it was well within the expiry date. And when we started analyzing the transfusion reaction, we noticed that this was observed post coming off from the cardiopulmonary bypass machine, and it also happened after transfusing that particular blood unit. Initially, they noticed that they were unable to ventilate the patient, where they noticed there was increase in the airway pressure, which we can see by these vital signs, where it increased from 24 centimeter water to more than 40 centimeter water. And this gave us a hint of some bronchospasm or dyspnea component which is involved here. Then it progressed to hypoxia, where the saturation fell down from 100 to 25%. Then there was bradycardia, which was revealed by decrease in the heart rate 102 to 30. And severe hypotension was also observed, where the blood pressure decreased from 120 over 58 to 30 over 15. And it led to cardiac arrest, and which required cardiopulmonary resuscitation to manage the patient. Then they managed the patient with CPR measures and some IV drugs. And initially, the bronchospasm was relieved, but they continued CPR. Then they had to go ahead with the vasopressors. And later, the post return of spontaneous circulation was achieved, and patient was stabilized and then shifted to ICU. Based on these reported symptoms and signs, let's try to evaluate and come at a diagnosis of a transfusion reaction. First of all, it was an acute transfusion reaction since it occurred within 1 minute. So it's most likely one of these 9 transfusion reactions that can be the diagnosis. If we see the clinical signs which were observed, there was dyspnea, hypoxia, bradycardia, and hypotension. So it suggests that it's mainly a transfusion reaction involving the cardiorespiratory system. So what are the differential pulmonary transfusion reactions that we can think of? It can be either primary involvement like TACO, TRALI, and TAT, or it can be some secondary involvement transfusion reactions of the cardiopulmonary system like anaphylaxis, acute hemolytic transfusion reaction, or transfusion transmitted bacterial infection. But there was also another component, hypotension. So what are the differential diagnoses for the hypotensive transfusion reactions? It can be transfusion transmitted bacterial infection, where along with hypotension, there will be mainly fever and chills can also be there. In the AHTR, also there can be fever, but it is associated somewhat symptoms like chills, back or flank pain, nausea, vomiting, and it can lead to DIC also. If it and TRALI is also hypotensive transfusion reaction, where fever and hypotension can be present, but mainly there will be dyspnea and cyanosis. And in anaphylaxis, some systemic involvement will be there, but along with that, there will be some mucocutaneous involvement in the form of urticaria, flushing, dyspnea, or laryngeal edema. And if none of the other criteria meeting, then that can be diagnosed as a case of transfusion associated hypotension, where hypotension is the predominant feature. Based on this differential diagnosis, we can rule out one by one which were not involved, like FNHTR, where there was no rise in temperature and there was no associated chills or rigors. That's why I want to rule out this FNHTR. Then there was no mucocutaneous involvement in the form of rashes or urticaria. That's why I would like to rule out allergic reaction at this stage. Now we are left with these 7 diagnoses, differential diagnosis. Here, this is less likely to be a case of TTBI, though hypotension may suggest, but there is no rise in temperature or chills which can suggest. So with the available information, I would like to rule out TTBI at this stage. But for confirmation, we need to do the culture of the patient, and pre and post. Pre should be available report, and culture of the blood bag can be done. And I would also like to rule out anaphylaxis. Why anaphylaxis? Most of the features suggest of anaphylaxis. Rather, it may be airway compromise or severe hypotension, and it required vasopressors for management. And there was a component of dyspnea and hypoxemia also. So there was involvement of cardiac system as well as the respiratory system. So systemic involvement was there, but we didn't observe any signs of the mucocutaneous involvement. That's why I would like to rule out anaphylaxis. Anaphylaxis usually happens as a severe grade of allergic reaction where there is mucocutaneous involvement. That's why I would like to rule out anaphylaxis at this stage. So now we are left with 5 differential diagnoses. If we consider TRALI, it has to meet the 5 definition criteria of the document provided by HPPI. It is acute in onset, yes. There is hypoxemia. The second criteria is meeting, yes. And but there was no any bilateral infiltrates which was observed on the frontal chest X-ray. This was the chest X-ray findings. This was pre-transfusion and this was post-transfusion reaction. And we didn't find any significant infiltrates that were observed. And that's why I would like to rule out TRALI also. And another criteria is just to differentiate between TACO and TRALI. And last criteria is only for the purpose of imputability. Where is there any alternative risk factor? And here actually alternative risk factor is there. So it means supposedly if it met all the criteria of TRALI, it will be a case of possible TRALI rather than a definite TRALI. And PaO2 by FiO2 ratio was also 430 mmHg. With this information, I would like to rule out TRALI at this stage. Now we are left with 4 differential diagnoses. And if you want to consider the transfusion associated circulatory overload, the definition says that there should be worsened respiratory respiratory compromise, which is there, but there is no evidence of pulmonary edema either clinically or radiologically. And there is no signs and symptoms of the cardiovascular system which suggests TACO, which are like tachycardia is not there, hypertension is not there, rise in JVP or the enlarged cardiac slit on X-ray, and there are no peripheral edema features in the X-ray also. That's why I would like to rule out TACO with this information. But additional testing which can confirm the or rule out the TACO is the B-type natriuretic peptide, where if it is increased more than if it is increased less than 1.5, then we can rule out the TACO. After this stage, we are left with 3 differential diagnoses. Either it can be AHTR, though the signs and symptoms doesn't suggest, but we need immunohematological workup to rule it out. And we are also left with transfusion-associated dyspnea and transfusion-associated hypotension. So to rule out AHTR, we went ahead with, or to rule out or rule in AHTR, we went ahead with immunohematological workup. On the check of labels and pre-transfusion sample, blood bag, and patient identification, all were correct. So there was no chance of clerical error. Then we checked for any evidence of hemolysis in the pre-transfusion sample and post-transfusion sample, and for any RBC contamination in the blood bag, and nothing was there. Then we did perform the blood grouping of pre as well as post-transfusion sample. It revealed to be ORHD negative. And we checked the sample from the blood bag, where we could do only the reverse grouping, and it revealed O group, but we cross-checked with the donor records of that particular unit, and it was found to be ORHD negative only. We did direct antiglobulin test and antibody screening by IIT, and both were found to be negative in both pre as well as the post-transfusion sample. So after the immunohematological workup, there was no clerical error, and there was no EBO incompatibility, and DAT and IIT was negative. That's why with assurance, we rule out the AHTR. So our diagnosis will be a transfusion-associated dyspnea and transfusion-associated hypotension, and it is independent of each other. Both the components cannot be clubbed together towards only one diagnosis. This transfusion-associated dyspnea, because there was respiratory distress within 24 hours, and it did not meet the criteria of TRALI, TACO, and allergic reaction. And predominant symptom was dyspnea. And since vasopressors were required for the management, I would like to give it a grade 3 severity. And there was also underlying bronchial asthma, and it was a case of aortic stenosis which presented with dyspnea and exertion. And this was observed post coming off from CPB pump. With all these features, I would like to give it the imputability of probable to this transfusion-associated dyspnea. If we consider the fall in systolic BP more than 30 mmHg, and the systolic blood pressure was less than 80 mmHg, and it occurred rapidly after start of transfusion, and this will give the diagnosis of transfusion-associated hypotension, and this is also of grade 3 severity with definite imputability. After the evaluation, the transfusion reaction report was attached to the patient records, and it was informed to the clinicians. And then the details were entered in the transfusion reaction traceability document, or the transfusion reaction register of our department, which you can see in the right side of picture. Then the details were entered in the Hemovigilance Program of India. And on follow-up, we came to know that the patient was discharged after 14 days without any sequelae which was related to the transfusion reaction, and patient is on regular follow-up. This is the document showing where we entered the transfusion reaction details to the Hemovigilance Program of India. Coming to discussion, in summary, this was an acute transfusion reaction. The main features were dyspnea, hypoxemia, and hypotension. We ruled out FNHTR and TTBI because there was no rise in temperature or chills. And because of lack of mucocutaneous involvement, I ruled out allergic and anaphylaxis. With the backup of immunohematological workup and the lack of symptoms of red cell destruction, I ruled out AHTR. And because they didn't fulfill the diagnostic criteria, I ruled out TRALI and TACO. That's why I gave the diagnosis as a probable case of grade 3 transfusion-associated dyspnea and a definite case of grade 3 transfusion-associated hypotension. How we were able to arrive at the diagnosis is mainly because of the signs and symptoms that were reported and the vital signs that were recorded. Why the signs and symptoms are important is, suppose if it is a case of FNHTR, even if there is no rise in temperature but chills are observed, we can diagnose it as a case of FNHTR. And mucocutaneous involvement is important for diagnosing it as a case of allergic and anaphylaxis. Then the signs and symptoms of red cell destruction can give us hint about the hemolytic transfusion reaction. And hypoxemia is an important component of TRALI, TACO, and anaphylaxis. Then dyspnea is the main feature of TAD. That's why reporting of signs and symptoms is very important to analyze the transfusion reaction. Why we have to record the vital signs is because sometimes what is observed and what is recorded may be different. If you take hypotension, on recording it may be reduction of blood pressure from maybe 100 by 80 to 120 by 80 to 100 by 70. They may call it as hypotension, but we know that according to definition it should be there should be fall in more than 30 mmHg. Then only we can call it hypotension. Like that, it is applicable with hypoxemia also, or rise in temperature also, tachycardia also. That's why the symptoms and signs should be recorded, as well as the vital signs should also be recorded. And why blood pressure is important? Because it is the main differentiating feature between TRALI and TACO, where there is hypo and hypertension respectively. Then in anaphylaxis versus allergic, if there is systemic involvement in the form of hypotension, that can differentiate. And in TAH, hypotension is one of the predominant features. That's why vital signs are important. And even while uploading or entering the details of Hemogenesis Program of India, the vital signs form an important aspect, and as well as the signs and symptoms, which are mentioned here, like generalized pain, respiratory, renal, and circulatory. And another important thing is radiological imaging, which is mainly helpful to differentiate between TRALI and TACO, or to rule in or rule out involvement of TRALI and TACO, where the bilateral infiltrates without left atrial hypertension suggests TRALI, and pulmonary edema features on X-ray, which includes lobar vessel enlargement or bilateral curly lines, it will suggest TACO. And of course, immunohematological workup is part and parcel, where we either to support or rule out the AHTR, and even for ABO mismatch, also to differentiate between immune-mediated versus non-immune-mediated hemolytic transfusion reactions. I would like to mention a few terminologies related to cardiorespiratory transfusion reactions, which are mentioned in various literatures. Some of them call it as cardiorespiratory transfusion reactions, or CRTR, and it is commonly known as primary and secondary pulmonary reactions. Some mention it as TAPS, transfusion-associated adverse pulmonary sequelae, and some mention it as a case of transfused ARDS. And there is a terminology called ABTR, where they expand it as allergic or bronchospastic transfusion reaction, where they say if there is any allergic or even if there is any bronchospasm component without the involvement of the system, even this can be mediated by the allergic reactions. And we know that generally in TACO, there is no rise in temperature, but that is classic TACO. If there is a rise in temperature, that is called as febrile TACO. And in FNHTR, generally dyspnea is not observed. If it is observed, it becomes either dyspneic FNHTR or non-dyspneic FNHTR. And TRALI, if it is with fever, they term it as co-febrile TRALI. And if there are no antibodies detected, whether it is anti-HLA or anti-HNA, and still TRALI is caused, they term it as seronegative TRALI. And if the recipient is already having the antibodies, and if it is caused by transfusing some antigen-containing components, that is termed as reverse TRALI. The transfusion-associated dyspnea incidence is not uncommon. According to International Hemogenesis Network database, they say that the incidence is around 2%, which lies between TACO and TRALI. So it is as significant as TACO and TRALI, the TAD. And the diagnosis of TAD is mainly because of the insufficient information to diagnose it as a case of TACO and TRALI, rather than confidently excluding it as a case of TAD. That's what is information rather than the confident diagnosis of exclusion. This is the various pathophysiological mechanisms involved in cardiorespiratory transfusion reactions. And based on this, a trial called Transfusion-Associated Dyspnea Prospective Observation and Laboratory Assessment Study. This trial, they're trying to classify the cardiorespiratory pulmonary reactions and investigate based on these pathophysiologies. Like it can be because of the hemolytic component. If it is because of the hemolysis, then they would like to investigate. Audible. Not audible.
Dr. Shivanand,
Am I audible, ma'am?
Yes, yes.
Till now you were able to hear, ma'am?
You're audible, but your slides are not visible.
Not. Is it visible, ma'am?
Yes, yes, yes. Continue.
So if it is based on the pathophysiology of hemolysis, then the investigations which will come handy are the CBC count, reticulocyte count, LDH, haptoglobin, bilirubin, and DAT, and the to detect DIC or coagulation screen. If it is involving the cardiorenal parameters, cardiorenal system, then it is mainly because of the pathophysiology of hydrostatic, where there is increase in the hydrostatic pressure that will cause the transudation. For that, to investigate, they are suggesting the N-terminal pro-B-natriuretic peptide levels, troponin levels, and creatinine levels for the renal component. If it is mediated by the allergic or vasodilatory or anaphylactic pathophysiology, then the investigation of choice are the bradykinin, anti-IgA, IgG, histamine, tryptase, and IgE. If it is because of the immunoinflammatory pathophysiology, then CRP levels and ferritin and IgG, IgA, IgM levels. And if it is because of the leukoagglutination, which is commonly observed with the TRALI, here they're suggesting for the anti-leukocyte antibodies like anti-HLA or anti-HNA antibodies. And they're also suggesting for the novel biomarkers like inflammatosomics, which consist of interleukins, mitochondrial DNA, or HMGA, which are damage associated proteins, and sphingolipids and extracellular vesicles. These are mainly because of whether these biolipids can result in the cardiorespiratory involvement of the transfusion reaction because of the RBC storage lesions. Based on this, they have suggested for the investigations following a transfusion reactions, which should be done. This is mentioned by the tadpole trial. In conclusion, I would like to say that medical history, signs and symptoms, change in vital signs, and immunohematological workup form the basis and important parameters to evaluate a transfusion reaction. And just evaluating is not sufficient. We need to report it back to the clinicians and attach to the patient records. And we have to enter it in our transfusion reaction register and also enter it into the Hemogenics Program of India. If we try to reduce the signs and symptoms to a single diagnosis, then there is potential chance of missing the overlap states or the complex presentations. And this diagnosis should be counted as separate events. Despite their appearing in a person simultaneously, they should be counted as separate because two reactions can happen simultaneously in a single patient. And the occurrence of one problem, it cannot grant immunity against the other. That means there is independent probability which exists for each adverse event after each transfusion for each person. These are my references. Thank you. I would like to conclude by saying the Hawthorne effect. Hawthorne effect means changes that the act of observation have on a phenomenon being studied. Here, the act of observation is the hemovigilance. The phenomenon that is studying is the transfusion reactions. So continuously we are incorporating changes based on the phenomenon that we are observing by the hemovigilance. Thank you, one and all.
Thank you, Dr. Shivanand, for that wonderful presentation. I think we will have a quick discussion, quick open session for discussion, 2 minutes before the next presentation. So the session is now open for discussion. Please, participants, if you have any questions, please unmute yourself and can ask questions now. I have one thing to ask, like, do you have a few words to add, like, about the primary and secondary causes of transfusion-associated hypotension? Like, is this say a case of primary or secondary? Because in some articles it's described that patients on AC inhibitors are more prone for secondary type of.
In this case, there was no history of taking any ACE inhibitors, ma'am. That we had ruled out, and I forgot to mention it, ma'am. But we had ruled out that one case.
Okay. Thank you. I think if there are no questions, then we can move on to the next presentation. The next presentation is about a singular tale of bleeding and factor V deficiency unraveled, a captivating case study. Will be presenting by Dr. Karthik Iyer, Junior Resident, KMC Manipal. Dr. Karthik.
Yes, ma'am, I'm audible.
Yes. Over to you, Doctor. You can start presenting now.
I'm audible, ma'am.
Yes, you are audible. You can start.
Slides. Okay.
Slides are also.
Good afternoon, all. Thank you for giving me this opportunity. I will be presenting my case report, a singular tale of bleeding and factor V deficiency unraveled, a captivating case study. Outline, I will be taking this case in two headings, case report and discussion. Coming to the case report, a 30-year-old nulliparous female, a known case of factor V deficiency presented with right-sided abdominal pain of 2 days durations on 5th of April 2023. The chief complaints were sudden onset of right-sided abdominal pain since 2 days. The history of presenting illness, the patient was apparently well 2 days back when she developed pain abdomen on right side of the right iliac fossa, which was sudden in onset, severe in nature and associated with headache and giddiness and was non-radiating. No relieving factor for the pain were present. Past history, patient was diagnosed with factor V deficiency at the age of 10 years at KMC Manipal itself. The past histories in the previously in 2013 of May, there was a history of fall developing a cystic swelling at the nose, and the diagnosis was 2 into 2 centimeter firm cystic fluctuant swelling over a bony part of the nasal septum. The significant investigations, which were HB of 7.8 of gram per deciliter and HCT of 25%, PT was abruptly abnormal 64.1 seconds and APTT of more than 120 seconds. The department of IHBT was not consulted at that time, and the patient was given FFP transfusion by the medicine department. On 14th of on October 14th of 2013, patient again presented with pain abdomen, and this time the diagnosis was a right hemorrhagic corpus luteal cyst with gross hemoperitoneum. Again, the significant investigations showed anemia, PD of 61.2 seconds, APDT of 90 seconds, and this time also the department of HBD was not consulted. Then again, when the patient again presented with pain abdomen with vomiting episodes, there was a diagnosis of pelvic hematoma formed. The significant investigations again showed HB of 6.7 gram per deciliter, PT of 53 seconds, APDT of more than 120 seconds, and this time the department of IHBT was consulted, and for which mixing studies were advised. The mixing study showed the PT was corrected with mixing with normal plasma with 11.2 seconds, and APDT was also corrected with 29.3 seconds. And in the inhibitor screen, the APDT control was 31 seconds, and the test was 33.4 seconds. And the control plasma with that incubated test plasma was 30.9 seconds. And that control plasma with test plasma non-incubated, it was 31.5 seconds. The PT was also was all on the normal range. The inhibitor screen was negative. And for this, the management advice from the department was FFP transfusions, which was with a dosage of 15 ml per kg throughout the course of the treatment. Then again, the patient on 21st of January presented with left thigh swelling. This time, she was having an hematoma of 6.6 into 8 centimeter swelling size. PT was 54.5 seconds, APTT was more than 120 seconds assay, and factor 8 assay was 162.9%. Again, the department of IHBT was consulted, and for which we advised FFP transfusion of 15 ml per kg. And then on September of 2022, again the patient presented with right ovarian ruptured hemorrhagic as the diagnosis, and again the department of IHBT was consulted. Since it was a diagnosed case, we gave FFP transfusion with 15 ml per kg as the dosage. Family history, as per the patient, no family member has been known for factor V deficiency. Drug history, no known allergies to the patient. Physical examination, the general condition was fair. BP was around 100 by 50 milligram of mercury. Pulse rate of 118 beats per minute. Respiratory rate 20 per minute. Pallor was present. Ictus was absent. Oral hygiene was maintained good. Mucous membrane were pale. Lymphadenopathy was absent. Clubbing, edema, cyanosis were all absent. Systemic examination, a thorough systemic examination was done. The patient was well oriented, time, place, and person. Respiratory was bilateral, symmetrical with thoracoabdominal movements. GIT, scaphoid abdomen, no scars. On palpation, tenderness present in the right ischial fossa, umbilical, and suprapubic region. Guarding was present. On percussion, dullness was present. A thorough urinary system was done. And the patient, and this time the patient had HB on a date of admission. The patient had HB of 8.6 gram, HCD of 28.2, platelet count 361, and showed the features of and then of anemia. Then on the next with. And on the 7th, when the tests were repeated, HB was 5.4 gram per deciliter, HCD was 15.8, platelet count dropped to 198, and at this time, the Department of IHBT was consulted. Since the PT was 52.2 seconds and more than 120 seconds, the department gave the advice to send a sample for thromboelastogram and fibrinogen assay. The fibrinogen assay came to 325 milligram per deciliter per DL, and the tech showed the features of hypocoagulable state. So, since the fibrinogen was on the normal side, it was the advice was given to transfuse FFP with 15 ml per kg as the dosage. And then after transfusion, the tech was repeated and it was normal. And since the patient was having anemia, 2 units of PRBC were advised for the correction. The referral smear was also done on 7th of April, which was suggestive of microcytic hypochromic anemia. And the diagnosis, which was concluded, was right hemorrhagic corpus luteal cyst with gross hemoperitoneum. After transfusion, samples were again sent for evaluation. The normal hemostasis was achieved with a PT of 13.5 seconds and APTT of 33.9 seconds. Transfusion reaction was noted after FFP transfusion, for which a thorough transfusion reaction workup was done and was identified as an acute allergic transfusion reaction. The management was done by on achieving the normal hemostasis. USG guided pigtail catheterization was done intraperitoneally, and 1800 ml of serosanguinous fluid was drained, and pigtail output was monitored. On the next day, USG scan was repeated, which showed no signs of hemoperitoneum, and the pigtail catheter was removed after 2 days after USG. It showed no free fluid in the abdomen, and the patient was discharged on improving symptomatically. Coming to the discussion, the coagulation cascade, the importance of factor V in the coagulation cascade plays a crucial role in the formation of complex prothrombin, converting prothrombin to thrombin. Since thrombin is a key enzyme that triggers the conversion of soluble fibrinogen into insoluble fibrin, thus forming a blood clot. Approximately 80% of the factor V is synthesized by hepatocytes and circulates in the plasma at 7 to 10 microgram per ml of concentration. The remaining 20% originates from the plasma pool through a process endocytosis by the megakaryocytes. Thus, in the coagulation cascade, the factor V-A and the factor Xa complex significantly accelerates the conversion of prothrombin to thrombin, increasing the rate of thrombin generation. And this is a crucial step, as factor Xa alone is not a potent activator of prothrombin and no alternate pathway to generate thrombin. Thus, factor V-A is essential for rapid and efficient thrombin generation during blood clotting. Coming to the cell-based model of the coagulation, the importance of factor V is, in addition to activating the platelets, the thrombin generated in the initiation phase cleaves the factor 11 to factor 11A and activates factor V to activated factor V on the platelet surface. Thrombin also cleaves the von Willebrand factor of factor 8. They circulate bound together, releasing it to mediate platelet adhesions and aggregations. The released factor 8 is subsequently activated by thrombin to factor 8A. But while in the propagation phase, the factor 10A generated on platelets then rapidly binds to the factor 5A, which is generated by thrombin in the amplification phase itself, and cleaves the prothrombin to thrombin. This prothrombinase activity results in a burst of thrombin generation, leading to cleavage of fibrinopeptide fibrinopeptide A from fibrinogen. When enough thrombin is generated, with enough speed to result in a critical mass of fibrin, these soluble fibrin molecules will spontaneously polymerize into fibrin strands, resulting in an insoluble fibrin matrix. Thus, summarizing the factor V with different functions, the factor V is activated by proteolysis mediated by factor 10A or the thrombin. After activation of factor V, this factor acts as a cofactor for the conversion of prothrombin by factor 10A in the presence of calcium ion and the phospholipid in the prothrombinase complex. The factor 5 before activation acts as a cofactor for activated protein C in the presence of protein S, calcium ion, and phospholipid to inactivate the factor 8. That is again an anticoagulant function. Activated factor 5A and factor 5 gets inactivated by the activated protein C and in the presence of protein S, calcium, and phospholipid. Coming to the factor 5 deficiency, also known as Auren disease or parahemophilia, it was first identified by Dr. Paul Auren in 1943. It manifests with symptoms ranging from minor mucosal bleeding to severe hemorrhages. The bleeding severity correlates to factor 5A levels, categorized into mild, moderate, and severe, based on the factor 5 in the plasma. Coming to the epidemiology of the disease, the factor 5 deficiency is a rare bleeding disorder that can be acquired or inherited. Prevalence of 1 per million live births, inherited as an autosomal recessive pattern. Both males and females are equally affected. No specific predisposing ethnicity has been identified. Higher incidence among countries where consanguinity is more prevalent. The inherited factor 5 deficiency is an autosomal recessive mutation at factor 5 gene with 1q to 23 to 25 can be inherited in a homozygous or heterozygous pattern. Heterozygous carriers are usually asymptomatic. The factor 5 deficiency is classified into type 1 and type 2 deficiency. The type 1 deficiency is quantitative, where both factor 5 activity and antigen levels are reduced. The type 2 deficiency is qualitative, where factor 5 is dysfunctional, leading to decreased coagulant activity, while factor 5 antigen can be low to normal. Symptoms usually present before the age of 6 years. Coming to the acquired factor 5 deficiency, the major risk factors include the autoimmune disorders, liver diseases, malignancies, infections, antibiotics, surgeries involving bovine thrombin. In acquired deficiency symptoms, acquired deficiency symptoms do not always correlate with factor 5 inhibitor levels. Duration inhibitor has been present, APTT, and PT prolongation of factor 5 activities. The manifestations of factor 5 often include mucocutaneous and soft tissue bleeding as ecchymosis, melena, hemarthrosis, hematuria, menorrhagia, hematemesis, petechia, epistaxis, hemoptysis, and bruising. As in my case, the hemarthrosis, epistaxis, mucocutaneous, and ecchymosis were the most predominant symptoms. Coming to the diagnosis, a thorough history has to be taken. Basic laboratory investigations include CBC, platelet count, PT, APTT, and thrombin time. The prolonged thrombin time, PT, APTT raise suspicions towards the common pathway of bleeding disorder. Further to be differentiated, mixing studies were advised, and further tests include factor 5 antigen assay, which is based on the principle of the test is a sandwich enzyme immunoassay, and the factor 5 activity assays, which is one-stage PT-based assays, Lewis and Ware methods, EDTA methods, and microplate activity assay along diagnosis with increased PT and APTT. The mixing studies will differentiate whether PT and APTT is corrected or not corrected. When the PT and APTT gets corrected, it's searched towards the deficiencies of factors, mainly of factor 5 deficiencies, factor 10 deficiency, warfarin or liver diseases. And when the PT and APTT is not corrected, searched for inhibitors, anti-5, anti-10, and lupus anticoagulant. Coming to the differential diagnosis for bleeding disorders, the prolonged PT is suggestive of factor 7 deficiencies and liver failure. Prolonged APTT mainly is suggestive of factor 8, 9, 11, and 12 deficiencies. Lupus anticoagulant, heparinase sample, or von Willebrand disease. Prolonged PT and APTT is suggestive of factor 5 deficiencies, factor 10 deficiencies, DIC. Lupus coagulant can also be seen in some cases with both prolonged PT and APTT. The management, the mainstay of the treatment in patients with factor 5 deficiency is like the on-demand therapy to elevate the hemorrhage as soon as possible. As there is no commercially available factor 5 concentrate, the only source of factor 5 for patients affected by factor 5 deficiency is virus inactivated FFP. The required dosage for coagulation factor deficiencies depends on the kind of treatment, like on-demand and prophylaxis, the minimal hemostatic level, plasma half-life, and most importantly, the type of bleeding episodes. Thus, the targeted dosages and the targeted therapeutic levels in patients with factor 5 deficiencies, like in on-demand therapy, the recommended level is 10%, and the dosage of therapeutic level 15 to 25 ml per kg of the FFP transfusion. In the long-term prophylaxis, the recommended level to maintain is 10%, which is with the dosage of therapeutic level 20 ml per kg 2 times per week of the FFP. Major surgeries, more than 50% to 20% in the maintaining level before surgery with the FFP transfusion of 15 to 25 ml per kg and 10 ml per kg every 12 hours. And with minor surgeries, 15 to 20 milligram per kg of 1 gram 4 times daily tranexamic acid. Thanking all. These are my references.
Thank you, Dr. Karthik. I think we have come across the end of our session. So the session is now open for discussion. Participants, you can ask questions now, or if you want to share any your experience with both the cases, both transfusion-associated hypertension and factor V deficiency at your own centers, please do share. Is there any questions? Please unmute and ask questions. Okay. Dr. Karthik, I think that was a really nice presentation. Thank you so much.
Thank
And
you.
this was the case of acquired factor V deficiency, right?
Yes, ma'am.
Okay, thank you so much. If I couldn't find any questions in the chat box also, so we will wait for two more minutes for any questions.
Yes.
If there are no queries, then we will wind up the session. I would like to thank both speakers. Thank you so much for the effort, and thank you so much for the presentation. And I would like to thank Tima's organizing team for conducting this CME seminar presentations. And I would like to thank all the participants who were present, who attended the presentation, attended the session. Thank you so much. I think is anybody there from organizing side will disperse a session, right?
Yes, ma'am. We can conclude the session now. The link for the certificates and feedback is given in the chat box. Everyone can log into that. We'll
Okay.
wait one more minute for any other queries. You can unmute yourself and ask the queries. So we embark the conclusion of another session of Clinical Club today. It was a wonderful presentation by both Dr. Shivanand and Dr. Karthik. I also extend my thanks to Dr. Judith for sharing this session. Thank you all. Until we meet again next time.
Thank you.